So the pelvic floor exam for non-physiatrists. When people come to a talk like this, what they're looking for is something they can just walk home with and start applying to their patients. So let's do that. The physiatrist exam of the pelvic floor is perfect. And I don't mean that as a vanity or a joke, but really it is just simple. Power, endurance, repetitions, fast, elevation, co-contraction, and timing. So, what are those? Well, power is our standard scale. We use 0 to 5, and it's called the Oxford scale. We know this. It's a standard way to test muscle power. The next thing is endurance. How well can a person hold the contraction that they're maintaining with their pelvic floor? Obviously, we're not going to use that sphincter that you see in the picture below, but the lower one that we can't really show on YouTube. But we tell them hold, 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 and then release and see how many times it can keep doing this. The next thing is repetitions, and not those muscles you see there, but the pelvic floor muscles. How many times can the contraction be repeated before the muscles fatigue? And that's what we're looking to see. The next thing is fast contractions. So quick, short contractions that tell us how the fast twitch muscle fibers function. The next thing is elevation. When a person contracts their pelvic floor, it lifts up. So that is a normal movement that we're watching for, but we can actually see sometimes some people end up blowing outward. The pelvic floor moves towards us and away from them. This is not normal movement. The next thing is co-contraction, where a person might start activating their face muscles or their hand or their abdominal muscles as they try to contract the pelvic floor muscles. And this is totally unrequired. The pelvic floor muscles can work without that. But some people have learned to recruit these muscles in an attempt to make their pelvic floor work in a way they think is more optimal. Can a person do a contraction without any further measure warning? This is what we're looking for when we look at timing, reflexive contraction of the pelvic floor at the right moment. And when we're done with this exam, we get an outcome. We get a diagnostic nomenclature that tells us one of four types of pelvic floor we're looking at. Either it's a painful or painless, hypo or hypertonic pelvic floor. And people will fit into one of these four categories, like painful, hyper, etc. But once we know this, we have an idea of what the pelvic floor function is like. The physiological basis for this is Wolff's law, where muscles adapt to stresses placed upon them and either become hypertonic or hypotonic. And this is essentially also linked to the law of reciprocal inhibition, where Renshaw cells in the anterior horn of the spinal cord will inhibit the antagonist muscles. Now, the question we have is that exam really perfect? And it's kind of quick and easy, but is it really perfect? It gives us the following information. Overall neuromuscular function of the pelvic floor, possible muscles involved, but we need more information to really treat a person. We need to see, are there myofascial trigger points? If they're there, why are they there? Are there specific muscles involved? Are the kinetic chains involved? Who are the persons that are affected? Things like that. Myofascial trigger points. What are trigger points? Essentially, they are scars that form inside the muscle because the muscle has been overstretched or held in a contraction. It is made to work too hard. And they feel fibrofatty nodules that are kind of slip under your fingers. Why do myofascial trigger points cause symptoms? It's just a scar in a muscle. But we know that it deforms the fascia around the muscle, and the arteries and nerves travel in that fascia. So the myofascial trigger point deforms these things, making them dysfunction. Now you can have a person with neuropathic pain. That's actually just a trigger point. Now it's may not always be clinically active, but it may be always active. And this is something we have to really understand. So the myofascial trigger points might stay inactive and they may not be hurting, but because they're there but not working, the muscle owners should work twice as hard. So they're always involved actively. But the real question is, why are they there? So we have to complete the exam. And to complete the exam, we have to look at posture. And looking at posture, we have to start with the ideal posture, where all the muscles in their appropriate length and they can generate enough passive force to keep the pelvic organs in place and enough active force to expel contents on command. But we have different posture types, and that's what you can see towards the right of this. But essentially, in an ideal posture, an ideal pelvis, then the muscles of the anterior and posterior parts are balanced out well. Now, the next thing is the kyphotic lordotic posture, where there's an anterior pelvic tilt. And the anterior pelvic tilt will overstretch the anterior muscles and possibly shorten the posterior muscles. The next is going to be the flat back posture, where the posterior muscles overstretch, anterior muscles are really tight. Or the sway back posture, which is something in between of these, the other two that we've mentioned. But they all have muscular imbalances that lead to myofascial trigger points in the clinical presentations we see. So how can we bring this all together? So there was an OBG whose name was Pescatori. And Pescatori tried to unify all these pelvic dysfunctions with his unified theory that essentially exposed different slings in the pelvic floor. So Pescatori said, here are your pelvic organs, the bladder, the uterus, the rectum, the vagina, because he's OBG, right? But then they all sit on a floor that they function through, and that floor has three slings. An anterior sling, a posterior sling, and an intermediate sling. So in an anterior tilted pelvis, the anterior sling muscles get overstretched. And then from there we can see stress incontinence, fecal incontinence. Keep in mind, this is Pescatori, he's OBG, so there's a fewer female biases. He never checked men. Middle ligaments can present with cystocele, abnormal emptying of frequency and urgency. And the last is back ligaments, which lead to rectocele, uterine apical prolapse, abnormal emptying, fecal urgency, nocturia, and pelvic pain. So we know the postures, we know the pelvic floor slings, we know myofascial trigger points, and we know how to describe a pelvic floor. We have to connect all this together to get the gestalt together. And that's where we bring the pelvic floor in and connect these two things. So connecting these two things is by the myofascial chains. And these are sets of muscles that have common origin insertions and a similar investing fascia. So a dysfunction, any one of these muscles somewhere can produce dysfunction, some other muscles and the fascia involved in them. So how do we link these things together? Here's one of the chains. It's called the superficial front line. You can see it with the arrow indicating it. It involves pectoralis major, the anterior core abdominal muscles, quadriceps, but it also links into pubococcygeus, puborectalis. And when this chain is in dysfunction, iliopsoas myofascial trigger points will emerge, and they can have urinary urgency, frequency due to excessive pressure on the pelvic floor. Pelvic pain can be aggravated by standing or walking. Here's a deep front line, a different chain that's usually going to be our erector spinae, our transversus abdominis, external oblique, internal oblique, and the adductors of the thigh. Now, that links into the levator ani, and the coccygeus, obturator internus, pelvic fascia. And when you have a dysfunction here, we can find pelvic floor myalgia, or difficulty with deep breathing or core activation due to diaphragmatic or pelvic floor desynchronization. Myofascial trigger points are the hallmark clinical feature of myofascial dysfunction in the body, and essentially they are muscle imbalances. You get a muscle imbalance, it leads to a trigger point formation. Trigger point formation irritates the fascia, which irritates the arteries and the nerves, and now you get this vicious cycle because they will further deform the muscles, causing more trigger points, causing more and more the irritation for the arteries and nerves until you have this vicious cycle going over and over and over again. So you've seen the physiatric pelvic floor exam. What are the outcomes of it? The outcomes are organic. We find something objective, and we can say definitely we can treat this. Non-organic. All the findings are negative. They complain about problems, but their exam is normal. And the last is mixed, where we find stuff, but it doesn't explain the full picture of what they're presenting with. Now, when we find objective evidence of a problem, we can use guidelines to treat. That's the hallmark of EBM. But if we can't, it's often labeled as a functional disorder, and whether we believe they have a condition or not, for the patient, suffering is reality. So it comes down to a decision. We can either treat people or we can treat a condition. And when you treat a disease, you could win, you could lose. But if you treat a person, you're going to win because you're actually treating the person. They know you care. And